Hello, I'm Humphrey Hawksley and your host for the next hour with Goldster's Purpose, Passion and Grit, where we talk to people who've gone through incredible experiences, overcome hurdles, helped others or been helped, and seen things through to the end. Today, we're going to be learning about an issue that has really impacted and changed all our lives in some way. Each of us has a COVID pandemic story to tell. We've all lived through the lockdowns, the heartache, the scandals in the news headlines. With me is a doctor who fought COVID on behalf of us all on the front line in intensive care units, where dreadful decisions had to be made tackling on the hoof a virus which everyone knew far too little about. He's written a book, Life Support, which I urge you all to read because it cuts through the fog and tells COVID as it really was, or maybe still is. Welcome, Dr. Jim Down, to Purpose, Passion and Grit.
Thank you very much indeed for having me. It's a pleasure.
And thank you for your time. Now, I just want to nail one thing down before we begin. I get confused about titles of doctors. Now, I'm going to call you Jim anyway, but GPs are doctors and consultants are Mr., or how does all that work?
It's surgeons who are Mr. And so I'm a doctor, and the reason they're Mr. is because they didn't used to be doctors. They used to be butchers. Well, perhaps not butchers, but they weren't medically trained historically. So although now it's a badge of honor for them, originally it's because the physicians were very snooty about surgeons.
Oh, so a surgeon is like a carpenter or a
yes, exactly, practical.
But you are medically trained, are you?
I am medically trained. I am. I've got some certificates somewhere.
You got us. That's great.
As are they now. I have to
say again.
As are they now these days.
Oh, thank goodness for that.
Yeah.
And we still call them Mr. and Doctor then.
So yeah, so exactly. Well, they become doctor, and then when they pass their surgical exams, they go back to Mr. Very strange. Anyway.
Great. And now I want to get to the COVID in a moment because it's an incredible story. But firstly, now that you are a doctor, what prompted you to join the medical profession?
Well, I'm from a family of medics, but I was absolutely determined not to be one until at about the age of 17. I eventually gave in and thought I'd do a bit of work experience. And that was it really. A week in the hospital, and I couldn't avoid it. I liked the contact with people. I liked the combination of sort of humanities and science, if you like, and it just sparked me off, and that was it. Although it was very much not. I didn't think I'd be doing this area of medicine, I have to admit.
What were you going to be, an astronaut, a train driver? What was your?
Oh, I remember when I did the survey at school, it was always hotel manager was what always came up. I have no idea why. But yeah, no, I had all sorts of ideas. I was going to go into TV, and yes, nothing that got very far.
Nothing got very far. You did, and then you write rather amusingly in Life Support, as you were qualifying, or as you qualified, that you dreamt of some sort of idyllic life as a countryside GP with family and dogs. And when I read through it, it reminded me of that TV series Doc Martin. Is that right? But it didn't happen.
Yeah, no, absolutely. That was absolutely what I thought I'd be. And then I had visions of myself with children on a beach and all that kind of thing. And then I did my GP placement. And I think my first clinic, 12 out of the 13 people had hay fever. And my second one, they all had backache. And I suddenly realized that I was not cut out for this at all. So I had to have a big rethink.
Not cut out for it, what? Because it wasn't taxing enough? It didn't.
No, it's not that. I think it's an amazing job, and that sounds a bit glib what I said. I mean, I think there's two things about it that are stressful to me. One is I realize that I'm not very good with chronic illness in a sort of GP setting, and the second thing was it's very stressful. I think this idea of having to send people away, with the risk that they might have something serious, is a really taxing and wearing job. And I have huge respect for GPs on both those counts, but I realized I couldn't do it. and they get a lot of bad press, but I think they're a hugely, well, obviously they're a hugely important part of our society, and I'm incredibly impressed by them, really.
Right, and so in a way that's booking. You were frustrated by the thought of sending somebody away and not being able to see a case through. So you went and ended up in the intensive care unit speciality. Is that a speciality? And therefore you were at that other end of it where people do end up.
Yeah, absolutely. So I mean, I've only really worked this out afterwards, but I've ended up at the other end of the spectrum, where it's there's no question that there's something really wrong, and we can look into absolutely everything. There's no shortage of the facility to investigate, and we can monitor absolutely everything. And the other thing is that the timescales, this is minute to minute. So I could do something and I could see it straight away, whether it was working or not, which is much more suitable to my sort of the way my brain works than the sort of week to week or month to month. And I don't think I consciously knew that at the time, but looking back at it now, it's clearly worked for me. And just to answer the other thing, yeah, ICU is a specialty now. It's young. It's only been its own specialty for about 35. Well, it only became really separate about 20 years ago, but it sort of developed in the last 40 years, really. The first ICU was in the polio epidemic in Copenhagen. That was the first time they put the sick patients together. And then it's just gradually grown from then. So
paint for us a picture of what an intensive care unit at a big hospital is like. Not COVID, but not in a normal day, who's going to be in there, what's going to be happening?
Sure. So I think the key thing about intensive care is that people come to it from all specialties. So it doesn't matter what you went into hospital with. If you get to the point where your organs are not working independently or are unstable enough that you need very close monitoring, then you come to ICU. So that's another appeal for me, is that it's, we see surgical patients, we see infectious diseases patients, we see heart attacks, strokes, everything. If the patient gets to the point where they need us to sort of support their vital physiology, then they come to us. So in our hospital, we've got 35 ICU beds in the main hospital, and then another smaller ICU. That's pretty big. But on the other hand, most hospitals are expanding their ICU capacity these days. So lots of hospitals are getting bigger. And each bed is a big sort of individual complex sort of unit, if you like, of life support. So it can, each one's got a ventilator, each one's got lots of monitoring, each one can give a patient dialysis. We can do whatever's necessary to try and keep the vital organs going until whatever's causing them problems goes away.
So your expertise in this is not how a kidney works or how a heart works or how cancer is doing. It is to keep the organs working, is it? It's to keep people out. That's what you're good at.
Yeah, absolutely. Yeah. So our job is interestingly, it's to keep them going while doing as little damage as possible. So what we've realized in the old days of ICU, we used to push all the physiology back to normal very hard. So we'd ventilate people hard and we'd give lots of drugs to try and make everything normal. Now we've realized that the act of doing that is actually more harmful. So we now do it as gently as we can, while the infection or whatever it is gets better. And then the other specialists come in, and we, obviously advise, and we work, collaboratively with them.
I was going to say, so you're working with a cardiologist or an oncologist or a renal specialist and that, but exactly. You're the guy that sort of you're the guy that's responsible for keeping those people alive and getting them out so that they can continue their treatment or their lives.
Yes, absolutely. Yeah.
That's a tough job. Is that an adrenaline junkie job?
It's I mean, I think like lots of things, it has its moments. It's a great mix of when the patients first come in, there's a lot of adrenaline usually because they're critically sort of acutely sick, and you've got to get them onto the ventilator, and things can be very unstable. And then usually not with COVID, but with lots of illnesses, there's then a sort of tail of them being over the acute illness, but having to then sort of build up their strength again to be able to function independently. So there's a mixture of the two, really.
So getting to the COVID thing, which has impacted us all, as I've said, you were, blasé is the wrong word, but you weren't convinced that it was going to be what it was. In fact, didn't you go on holiday or something?
Yeah, no, I mean, I wasn't convinced. Very early on, I wasn't a totally late adopter, but in January, February, I was very much in two minds. And the reason for that is because we'd had these scares before. I remember the SARS pandemic and being terrified, partly because healthcare workers were obviously dying. And then, of course, because of the nature of that virus, it was terrible in small areas, but was controlled. And then we've had, bird flu, swine flu, etc. And none of them have really come to too much where I am in the UK. So we've just become slightly blasé, I think. And then, of course, as February turned into March and it hit Italy, we all realised that this was not like anything we'd seen before, and there was no, the chance of it being a mild flu was zero, really, and that's when everything changed.
So you mentioned February, March, but at that time, your 35-bed intensive care unit still had your renal and cardiology, your normal patients in there. It wasn't, you didn't get a sudden influx of COVID patients.
No, it was slow to begin with. I mean, it was like, any exponential thing. So we had 2 weeks of trickle. And in fact, the first couple of patients that came through were only mild COVID. And we gave them a little bit of, high flow oxygen or the tight CPAP masks, and they got better. And I remember feeling quite confident and quite ahead of this and thinking we're going to be all right until sort of middle of March, when suddenly it hit us like a tsunami, and some really sick patients, and that was a big shock.
Was there one patient that you had, or one day that you can remember where, as you said, it hit you like a tsunami?
Yeah, there's one patient that I'll never forget, who was a 28-year-old who previously fit and well, and he we don't know why, something in his genetic makeup or something in his physiology just meant that it absolutely ripped through him, and he died on, I think, my third or fourth full day on the unit, and I was absolutely shocked, because I'd still at that point thought this was going to be pneumonia of the elderly, or those with with health problems, and he didn't have either of those. His next of kin was his mum, and that really, and it was I think from that day on that we all kind of thought, this is not just about scale and numbers. This is about a disease that is new and unbelievably serious, and also unpredictable.
So at that time, I remember we were, all watching the news, and we were saying that all with underlying health conditions. Mm. A 28-year-old come in, and in a matter of days, he was dead. Mm. Goodness.
Yeah, absolutely.
Yeah. You also had a colleague you write about called Rick, who was kind of ahead of the game, and I presume around this time, he was actually giving out warnings and setting up systems in your hospital that put you a little ahead of the game?
Yes, I think he was. I mean, he was great. He sort of emerged. He's quite a young consultant. I'd always known he was sort of very clever and innovative, but he watched the numbers, I think, or the national numbers, and then spoke to a couple of friends, and then in his head did a couple of calculations and thought, hang on, we're being lulled a bit here. This could be a lot worse than we were expecting. And he called us all in one Saturday night, which was in those days was quite an unusual thing to do. These days that would seem quite normal, but I remember it well because everyone turned up, and he put up some terrifying graphs about how the numbers we might be facing. And really from that moment on, we thought, right, we've really got to change accelerate our preparation and take this much more seriously. And and then he became our sort of de facto leader, our in-house leader, and we all fell in behind him very quickly.
At what stage then did you dress up in the PPE, and was that then, or was it later, or?
No, we had this strange period of sort of preparation about 2 or 3 weeks before that Rick's meeting, and then a week or so after, before we were we were in very high numbers. So we tried to practice all these things. So we put the stuff on and we took it off, and then we ran scenarios and of everything we could think of that might happen. And it was very strange because this was all really helpful, but it just also made you more and more anxious. And so by the time I actually got in to look after some patients, I was sort of, had this, what people have described as anticipation fatigue. I really needed to get on with it because I sort of prepared for too long, and actually getting into the room with all the kit on and seeing everyone else just getting on with it was almost like it was a relief in a way. You thought, oh yeah, okay, now we can get on with this. It's the sort of fear dissipated.
At the stage that you went into the ICU dressed up like a PPE spaceman, as it were,
yeah,
how many of your patients had COVID, and how many of them were the normal ICU cases?
So by then, I was not on the first week. By then we had 2 bays, so we had about 8 COVID patients, and then the rest of the unit was non-COVID. And we just started to do a daily meeting where we put a huge chart on the wall and working out our beds and working out how we'd expand. And then very quickly, within a week or so, the non-COVID disappeared and was taken over by COVID. I mean, it was very quick.
So what happened to those people that had failing kidneys and failing hearts and leukemia and all that sort of stuff?
So I mean, this is the side of it that's amazing. The ones already in there would generally move to another hospital. So a couple went to private hospitals. Some got better and got out of the unit. And then we have a satellite hospital, and that became our elective surgical centre. Mm-hmm. And then in terms of the leukemics and things, they stopped doing bone marrow transplants because they had to, because the risk was so high for the group. So
that's when your immunology goes down completely.
Exactly. And if they caught COVID, it was in fact, one of the patients I talk about in the book was, I think, the last person to have a bone marrow transplant, a chap called Jonathan, before they stopped the program. So a lot of our work went elsewhere, but also a lot of people just stayed at home. I think, people didn't turn up in A&E like they normally do, because for many reasons. I think people were terrified of catching COVID in hospitals. I think people didn't want to, felt that the health system couldn't cope. And so I think I think we all know one of the tragic side effects of it is that people didn't get treated for other things as early as they should have.
And take us into the ward at the height of the COVID thing of your day. I mean, just explain to us, what on earth was it like?
So it was, it was like unlike anything I'd ever seen before. So the hospital basically had become COVID, our hospital. There wasn't really much else going on. So there were wards with not so sick people just on some oxygen, and then there was our ICU that was full of COVID, and then our theatre area, which is 12 theatres and a 13 bedded recovery area, that had become one big ICU that filled up with 22 patients, I think, at the peak. And then upstairs we had another 20 to 25 beds that were also full of ICU patients. So basically we tripled in size as an ICU. But that means every ICU patient normally has one nurse with them all the time. You have one doctor between 4 or 5 of them. It's very, they've all these patients were on ventilators or tight CPAP masks. So the whole place was completely unrecognizable. And then also all the staff were in full, masks, double gloves, visors, hats. So you couldn't really see who was who. So it was like being in an alien environment for everyone.
You couldn't even recognize your colleagues. I mean,
so everyone wrote their names on their fronts and their job, just because otherwise there was no. And also, our staff tripled in size, so there were huge numbers of people that I'd never seen before, who were suddenly just come to help from within the hospital and from other hospitals. So it was extraordinary. I mean, it's sort of indescribable.
I'm going to ask you to give some uplifting cases later on, but what's one of the worst cases that you saw, that you dealt with there, the most disappointing, that impacted you?
Yeah, I mean, I think, so there was the young chap I talked about at the beginning, that sort of traumatized me in made me feel very anxious and worried. The person I perhaps connected most with and emotionally upset me the most was a chap in his 40 the chap who'd had the bone marrow transplant.
Oh.
And he because he came in and was awake for the first 5 or 6 days, and he was really determined. He was a lovely man. He had 2 young kids, and I'm always very wary of the sort of people fighting illnesses and things. I think that's, I always feel slightly worried about that metaphor, but he really looked like he was gripping the sides of his bed, and he was determined, because he knew that if he ends up on a ventilator, having had with his leukemia, he was very unlikely to survive. But eventually he and I both knew that he had to go off to sleep. And of course, at this stage, families couldn't come in at all, really, or very little. So we rang his wife on an iPad, and we had a sort of 3-way conversation about him going off to sleep. And it was just incredibly moving and upsetting, because they were very undemonstrative, but they told each other they loved each other, and she reassured him. And there was something about it that I just felt like they could easily be at the school gates, as I was picking up my kids. And he was then ventilated for about a month, but eventually, he deteriorated. He just didn't have the reserves and the immune system to deal with it. And his wife could never come in because she had asthma and she was shielding.
Oh goodness!
So it was very. It really got to the heart of it for me, because so you'd ring her at home and you'd hear the kids running around in the background, and it just sort of summed up the horror of the pandemic.
I mean that is that's a dreadful story. And you didn't know, or we still don't know exactly what this virus does. So you were, when you look at a case like that, do you feel a helplessness that you don't know where it might go next?
Yeah, I mean, absolutely. So before it hit, we were all worried about numbers and our own health, if I'm honest. We thought, are we going to get this, and how many patients? 2 weeks into it, we were thinking, what is this disease? It's like nothing we've seen before. What should we be doing? Should we be ventilating people on their fronts? Should we be thinning the blood? Should we be giving steroids? All these, we just didn't know what we could do the supporting the organs, but we didn't know what specific treatments to give, and no one did. So the whole world was trying to learn what to do. And that does make you feel helpless. Sorry.
Excuse just a moment. I've got a car or something outside that's sorry about that. That's the trouble with these things. But explain what a ventilator, how does it actually work? I mean, you know, we hear about it a lot. We think we know what it means, but what actually happens to you when you're ventilated?
Yeah, so usually you need a tube down through your vocal cords into your trachea, into your windpipe, and that's incredibly uncomfortable. That's worse than having a surgical incision in terms of how painful it is.
Yeah.
So you have an anaesthetic for that to go in. Now, normally that's very straightforward and not a problem. With COVID patients, as I described in the book, that procedure in itself was pretty terrifying because they were so hungry for oxygen and low on oxygen that as soon as you put them to sleep, their oxygen levels plummeted, and that was, so that was very tense for us. But then once the tube's down, basically, initially we have the patients paralyzed, so they can't breathe at all, and we do the whole thing for them. So we blow in, 20 breaths a minute with a certain amount of pressure, and try and keep, and we can fiddle with that, and we can nuance it, if you like. We can alter it to try and fit their physiology, try and keep their oxygen levels acceptable.
And the patient is unconscious, essentially.
Yeah, so then they stay in an anaesthetic basically until either we can take that tube out or we can move it down to a tracheostomy, which is much more comfortable.
Goodness. Yeah. And this is why people didn't want to be ventilated, is it? Because they, not a lot of them came out of it? There was a percentage I read.
Yeah, so absolutely. So by the, if you ended up on a ventilator, your chances of getting off it were roughly 50-50, which is pretty shocking thing to know. Now, we didn't know that right at the beginning. Of course, by the second wave, we had a pretty good idea, and some of the public knew as well. So people in the second big wave, in the next Christmas, people were very reticent to go on a ventilator. And some people, until they were actually unconscious from not being able to breathe, refused. And then we did it at the last minute, which was far from ideal. But I understood, I got it. I understood why they wanted to just do everything they could to avoid it, because it could be the last time they're awake.
And you've given a very sort of graphic picture of this environment that you worked in. And this was for you day after day after day, going on for how many months was it?
And night, I just have to point out. So I hadn't done a resident night shift for about 15 years. So suddenly going back onto nights was interesting for my body clock, my aging body clock. But so we it was the first wave started, I suppose, in the second week of March, or third week of March, and it went on till it was about 2 months, 2.5 months of really intense. And then it, interestingly, as it went up very quickly, it also went down quite quickly as well. So we had patients who were incredibly sick and unstable for weeks and weeks, but then suddenly, if they'd survived that, they'd turn the corner and get better much more quickly than we expected, which again, I still don't really understand. But so they got out of ICU quite quickly, and by June, we only had sort of half a dozen left, and some of those stayed a long time. They were much slower to get better.
I mean, we talked about your colleague Rick and the systems that they set up, and there was stuff that we were all watching about whether we should go into lockdown or what the figures were, and stay at home, don't stay at home, and now we've got all the Partygate scandals and everything.
Yeah.
Come from that. Was that a different planet to what you were working on? I mean, did you think we're going to do it our way because we know this is the way that's working for us?
So we changed as it went on. Look back at those first few days, and everyone was in the hospital all the time, even if they weren't clinical, trying to, organize things. We were all huddled in rooms. And then very quickly, half of us went down with COVID. And that really made us think, what are we doing? This is madness. And from then on, we started, and then because there weren't really Zoom meetings, were there? I mean, when it
No,
started.
Zoom, I mean, a lot of things came out of COVID, didn't it? And
Yeah,
Zoom was
yeah.
one of them, and how we communicated and everything. But no, I mean, you say in the, you talk about this a lot in the book, but one phrase that got me is that however expert you are, you're only ever offering an opinion. I mean, you didn't know what was happening, and you were taking the best bet on it.
Yeah, I mean, I was, I'm very wary of the limits of my expertise. On the shop floor, it felt as if the lockdown was crucial. We saw the tailing off of, or the flattening of numbers after that, and so in the hospital we were very pro the lockdown. How you do what you do now, I think is much more difficult. I'm still a big fan of masks. I still think for crowded spaces they feel sensible to me, but I know there's a lot of opinions about that, and I know that we've got to find some form of new normal, haven't we? We've got to somehow learn to live with it.
But is it the case that the first strain or variant that we had, we didn't know what it was, and it went and attacked all sorts of organs and that. But each time it seems to morph into a different variant, it seems to get less. So is that right, or is that just hoping?
Interestingly, the first two were similar. If anything, the second one was a bit more severe, possibly, and marginal. So if you think about the one that hit Christmas 2020 and through January, February of 21, that was definitely as bad as the first one. That was the Delta, wasn't it?
That's Delta.
But then but as that came, of course, we got vaccines, which helped hugely. And then I think the Omicron, as I understand it, is both much more mild, and we've got the vaccines. I mean, through the second half of last year, we saw a steady rate of, so we roughly ran at about 10 ICU COVID patients from about July till December or so.
Right.
Almost all unvaccinated. And that was really, very sad to see, obviously. But that's now tailed off with Omicron. We're seeing very few. We're seeing lots of people who test positive, but they've not got, the COVID.
And by the time they reach you, they're in a pretty bad condition anyway, aren't they? So there's lots of other stuff going on that wouldn't cross your ward, as it were.
Yes, and there have been, I don't know the numbers, but there's been an impact of Omicron as in ward level patients, absolutely.
Right. Yeah. No. I asked you to give a worst case scenario. Now give me an uplifting one where you're in this ward, it looks dreadful, everybody's covered up in this stuff, and there's a case that you remember now that brings a smile to your face and maybe thinks, yes, this is the job I love.
Oh yeah, so I mean there's a few, several of which I mentioned in the book, but the one that really stands out to me is a young chap, again in his 40s, fit and well, got married the year before, he had got married the year before, and he was incredibly sick. And I met him before he came to ICU. I went to see him on the ward, and he just looked dreadful. He was curled up over his tray table in his bed, panting away, determined to carry on. The next day he came down. We had to put him on the ventilator, and for I think 5 or 6 weeks, he was absolutely at the extremes of life. He was being turned onto his front every day just to keep him alive. And then suddenly, we were all carrying on, but we all felt it was hopeless. And then suddenly he turned around, and within a week was off the ICU. A few weeks later, out of the hospital. And then when I rang everyone to get their permission to be in the book, he was back at work and said, let's go for a drink. And he drank me under the table. And he's back doing his high-powered job. He's racing. He's a huge offshore rail sailor, and he's off doing that again. Bought a boat, and he's had a baby. I mean, so he's my real sort of.
So what is it in the human body that it makes that happen? I mean, that one person doesn't make it through, one does. There's no rhyme or reason to it.
No, I mean, the geneticists are looking at it, aren't they? And they're looking at COVID. I mean, it's fascinating because, you know, at every stage, why do some people just get a very mild illness, some people asymptomatic, some people ICU, and why do some people get long COVID? You know, it's just extraordinary.
Yeah, and you haven't had it, have you?
I've still not had it, unbelievably. No, I keep testing. But I slightly feel my time will come at some point.
I mean, let's hope it's for one of these lesser strains. Now, Dr. Jim Down is with us. We've heard about that. We've got a lot more to talk about. But if any of you've got any questions about COVID, about the treatment, about the systems, about your bodies, and where we're going with COVID now, put it in the chat, and we will pass it on to Jim. Don't be afraid. The only stupid question is the one you never ask. So, but your family. So let's go back to the beginning. You've got Rick is calling you all in for a meeting. You know it's going to be bad, but you're married. You've got children. You're going home. I mean, how do you say to them, look, I'm going into this terribly diseased place and I'm coming home every night? How does that work?
Yeah, so we talked about that at home, and there was a small window where, well, there were two options, I suppose. I could have gone into a hotel, or my family could have gone away to my in-laws. And I was very nervous about it. I'm generally a sort of, I think comes across in the book, I'm the sort of hypochondriac doctor, and I was worried about, and I, you know, scrupulously clean things. But my wife is much more relaxed, thank goodness. And she just said, you know, we're going to stay here. I don't want to put my parents at risk. She was quite insistent that I came in and had a shower and all that kind of thing. But we made the decision that we didn't know how long it was going to go on. You know, we'd just go through it together. And that was, I mean, hugely important to me. That sort of saved me, because coming home and you know, being brought back to earth by two very rumbustious sort of 10-year-olds was absolutely brilliant. And I remember when there was the clapping going on, and I missed a few weeks, but I went out on the third or fourth week, and and I said, "Come on, kids, we're going to go and, you know, clap all the people." And my kids, oh God, Dad, and they came down and they developed a new thing, the sarcastic clap, when they just do one clap and go, "Is that enough, Dad?" Which was wonderful, actually. Just completely, you know, sort of.
I think you've got a bit in the book there. I can't remember where you mentioned something. You said there's no chance of my daughter ever reading this, so I can say.
Absolutely, no. I think there's. Well, she hasn't read it yet.
Yeah. So at that stage, were you, when you finished your shift and you took your space gear off, did you test? I mean, how did that work before you went home?
No, we didn't. We tested regularly. I mean, it varied how often, but, you know, we test once or twice a week with the formal test. And then lateral flows came in a bit later. But generally people tested, you know, with the formal PCR test, which is difficult because they didn't come back for 2 or 3 days, so you could be positive. So it was messy to begin with, and now these days it's much easier. I mean, you can do a lateral flow. Well, you could, until they disappeared, do a lateral flow very, very quickly, which was hugely helpful, I think.
We have some questions coming in now, Jim. Justine Gillen says, are some people thought to be immune from COVID?
Well, yes, I don't. I mean, so I've not got antibodies. So by that, I mean, I didn't have antibodies. I've obviously got some now with the vaccine. But after the first wave, I had the test. I was sure that I was going to come up as having had had an antibody test, I was sure I was going to have had it and had just been asymptomatic. There wasn't a sign of anything. So by that mechanism, I wasn't immune. But there is a possibility, I think, and I'm not an immunologist. My understanding is that you can have, there's T cells in the immune system as well, and some people may react to the virus with those, and therefore never get, never go positive by antibodies. So I suspect there are some people who aren't susceptible, if you like, and I'm clinging to that.
How many of your kitted out people that went into that, how many of those came down with it when you didn't?
So that's very interesting. So we thought we were the bravest people at the front line and everything, but actually that's far from the truth, because the kit worked. And there are studies now showing that if you worked in a hospital, your risks of getting COVID were higher and of getting sicker were higher. But if you worked in ICU with the stuff on, they weren't. You were the same as the rest of the population. Now that only has come out more recently, but so the people at real risk were the people like the cleaners, the people on the front door, who were constantly in contact with people but didn't wear the full
and I guess, getting back to us right at the beginning, the GPs and the GP surgeries would they had nothing, did they? They just
and bus drivers. I mean,
yes.
We in London, there were lots, a very high level of poor bus drivers, who carried on throughout. I remember looking out of the window of the hospital, and all there was on the streets were buses.
Yes,
which was,
Lilette Butler asks, what happens to the lungs in COVID? Does it cause permanent damage to cause long COVID, or what is the damage or what causes long COVID?
So long COVID is a mixture of lots of different things. It's fascinating. It's not what I do, but some long COVID is lung. So some people end up with lung damage, but not all by any means, and not even if you're at death's door when you're acutely ill. If you get better, some people don't get long COVID. So it's very odd. But certainly there are people who've come out of it and still have CT changes of inflammation or fibrosis later, where it's sort of scarring of the lungs. The other bit of long COVID is under the tiredness, all those kind of things, all the headaches, the lack of taste, all the different things people have got are being investigated all the time. And I hope, and my sense is that because it's COVID and there's so much research now into it, the whole sort of post-viral illnesses will get a lot more attention and a lot more research, and the whole sort of chronic fatigue syndromes and things will become much better understood.
Well, that gets Jean Joyce sort of leads on from that. How has the treatment for COVID changed over the last 2 years?
So yeah, I mean, so there are new, as everyone knows, there are new drugs in ICU. We've got about 2 or 3 new drugs, and we've and then before that there are antivirals now that have an impact, and there are other things still being tested all the time. And then we've sort of coalesced as a community to certain strategies, but there's still quite a lot that we disagree with around the world. And it's quite interesting that people still have the opinions. Well, like much of
when you say disagree with around the world, disagree because let's take Rick and your hospital and your sort of unit there. Do you disagree with other people in Britain, or do you disagree with the people in Taiwan or Russia? What do you mean by that exactly?
We disagree with each other on our unit. We always do. There are different ways of doing it in all ICU. They're small changes, and at the beginning we were having 3 ICU consultant meetings a week, trying to find some communality. But then if you look across to St Thomas's Hospital, less than 2 miles away from us, they went down a very different route at the beginning, in that basically they were putting people on ventilators earlier than us because they thought it was safer. We were using
Thomas's
CPAP.
is where the Prime Minister went, isn't it?
Exactly. Yeah.
Right.
Yeah. Thank goodness he didn't come to us. And we've gradually sort of come to the middle a bit. In terms of around the world, I think there's quite a lot of. The other big thing is resource. So even in the UK, a different hospital, our hospital has loads of oxygen, whereas we didn't have that many ventilators. St Thomas's Hospital has loads of ventilators, but has a limited supply of oxygen. So that pushes you one way a bit as well. So there's lots of factors happening.
And where does the authority lie? I mean, do you have to report to senior management, or is it your unit led by Rick unofficially that can actually make these decisions?
No, we can. That was amazing. We could really do what we wanted, and not only that, we could ask the hospital for what we wanted in terms of support. Yeah. So it was amazing for Rick and people like him, because they could just go, look, we need to do this. I need to convert that ward into an ITU over the next week, and it would happen.
This is very refreshing, because it's medically doctor-led as opposed to bureaucrat and manager-led.
Yeah, it was completely doctor-led, and I think rightly for this time, this was a national emergency. I mean, I think normally it does need to be a little bit of a collaboration. I'm not sure doctors have all the answers in terms of how to use the national finances, but for this it was brilliant. That side of it was extraordinary. I remember meeting the chief executive, and he just he was a medic, in fact, where I work, but he just said, do it, go for it, and whatever we said, it was extraordinary.
Oh, God. Geeta says, if somebody tests negative in a lateral flow test, can they still pass on COVID if they are incubating it? Tell us about lateral flows, PCRs, and all that sort of.
Yeah, so there's no 100% in any of medicine, and certainly with these tests. Lateral flows, are great, and they do pick it up before you're symptomatic, but they definitely have false negatives. So it is possible to be negative and to pass on COVID. I think that the problem is how do we live? How do we live with COVID as this new world is? And I'm now at the stage where if I'm going to a place where I'm worried about passing it on, I do a lateral flow, and I sort of accept, and I tell the person, and I feel that that's my current sort of status of caution.
Did you, it was obviously an emotional, impactful thing. Did you sort of become, is political might be the wrong word, but when you were hearing that we're going to stop the lockdown, or we're going to let people travel again, did you think, oh my God, no, or thank God, or?
No, we got very nervous. Yeah, I generally, I think, I've got to be careful. I'm biased. I'm only seeing one angle of this. I'm not seeing the mental health impacts. I'm not seeing, the financial impacts, all those things. So I'm very aware of that. But from our perspective, we were always hoping we'd go into lockdown a bit earlier and hoping we'd come out a bit later. But I don't claim to have the right answer to that.
But you talked about mental health impact. It must have had an impact on you. Talk about that a bit.
Yeah, it did. Funnily enough, I think it had so my personal experience was, after the second wave finished, I then had a non-COVID case that had a bad outcome, and that one flipped me over the edge into a sort of period of anxiety and depression, and luckily I've got fantastic colleagues, and they looked after me, and the hospital looked after me, and my GP looked after me. I was very lucky, but I had a sort of about a month to 6 weeks where I sort of I decompensated, if you like. took up cold water swimming and various other sort of classic things.
So just go back on that a second. You obviously had all this built up tension and stuff going on for months and months, and then a case comes in that is not COVID, and it didn't go well. I presume the patient died. What flipped? How did that flip? Did you?
I just I questioned myself was the first thing, and then I went back. I used, I think we often, if a case doesn't go well, we go and talk to colleagues, and I did that, and they reassured me, that they'd have done the same. There's nothing we can do. But for some reason, because I think it had built up, I was right on the edge, and I'd just been sort of, keeping it just about under control. I just couldn't suppress it. So I believed my colleagues for a couple of hours, and then my mind would start to ruminate again on the what ifs. And, I think as a lot of people find with sort of anxiety type depression, I stopped sleeping, I stopped being able to concentrate. Now, luckily, as I think you get from the book, I'm an oversharer. And so I think
talk about it to people.
So I went and talked to people, and of course, if you do that, you find that there's loads of things. Well, I'm certainly where I am. There's lots of support, and so I managed to sort of access that. What worries me, I think, is that, and in fact, I did a lecture about this to our department. I just thought, well, I'm gonna, can it do any harm to tell people exactly what happened to me? Yeah. And from that, people have come out saying they feel similar, but other people find it much more difficult to sort of open up about that, and that's what really, I think, worries me.
Justine asks, how many fellow staff members suffered with mental health issues throughout? You were not alone, I presume, in that.
No, I think a lot of people did, in very different ways. I remember talking to a colleague, because I think historically we're not good at talking about it. So there's a slight element of, keep your distance, keep functioning, sort of stiff upper lip type thing in medicine, which has changed, I think, probably accelerated by the virus. And thank goodness it has. But I remember saying to a colleague of mine, how have you been? And he said, oh, no, not good. I said, well, what do you mean? He said, well, I haven't slept beyond 4 o'clock in the morning for 6 months, I just realized. And, but he sort of just got used to this thing as his normal.
Is it the work pressure, or is it the guilt of the people that didn't make it? What's the trick?
I think it's a mixture of it all, but I think you're right. I think we're all haunted by some, for me, that's this chap Adam, but by, the scale, the severity, and guilt about the ones who didn't survive. Particularly early on when we were learning.
Because you say in the book, you've got a line about, you were using treatment strategies that might be wrong. That because it was an unknown.
Yeah.
And
that's very frightening. And
should I have done this, and then the life would have been saved? Is that the thought?
Yeah, no, absolutely. And if you're going off on a tangent different to another hospital, it crosses your mind. What if our mortality's 60% and their mortality's 20%? We're going to look. It's just going to look awful, or it is awful. So there was all that kind of thing, in the back of our minds. Now, as it turned out, we all did quite similarly, all the big institutions, and we were lucky, but that unknown thing, I think really people paid a price for that.
And how does that tie in with your choice originally to become an ICU specialist? Are you still going to do it, or are you going to run off to try and be a GP again?
I'd still be a terrible GP. I have wondered, and when I had this moment last year, or more than a moment, I did think about the other things I could do, and but realised that there weren't that many of them, and so I will carry on. I think I'm a different doctor than a different ICU doctor to the one I was. I think I'm a bit more aware of my vulnerabilities and things, I think. And
is it your daughter that said, are you wiser and sadder, you mentioned in
that was a journalist.
A journalist said that.
Yeah, a journalist said, and it was very interesting. And then then my daughter picked up on it, obviously.
And also you're going to continue to be an author, which we're going to get to in a minute, but stay with us, Jim. I want to tell our audience out there what's coming up on Purpose, Passion and Grit. Tuesday, April the 26th, that's a week from now. Goldster's Alistair Hignell is with Mary Peters, who's an Olympic athlete, a world record in the pentathlon at the age of 33, and she founded the Mary Peters Trust to train talented young sportsmen and women, and she's a patron of the Outward Bound. On the May the 3rd, 2 weeks from now, Goldster's intrepid Rosie Stancer is with Anne Daniels, a polar explorer, one of the first women to reach the North and South Poles as part of all women's teams. Rosie, of course, as many of you know, is a polar explorer herself, extraordinaire. And then on Tuesday, May the 10th, Goldster's wonderful Lucinda, my counterpart, is with the Sarah Hope, the founder of Elizabeth's Legacy of Hope and the Sarah Hope Line. And after a London bus in 2007 ran down her family, killing her mother and causing her daughter Pollyanna to lose a leg, the anger, she set up a trust for amputees and a charity to help people injured by London transport. Do you empathize with that, the guilt and the anger then, Jim?
Yeah, no, absolutely. Yes, I feel for her terribly. I've just been writing actually about my involvement with the London bombings from the transport, obviously from the transport sector, and it still haunts me, that to a certain extent. Yeah,
it must be millions of people. We've got this anger and guilt of things how we've let people down, and that. And you said you've just been writing. You are writing another book, but is it about COVID again? What is it about?
No, so. The second book is much more general, so I think it's probably best described as all the things that worry me about the job. So it's based around cases, but from my whole career, and then the issues that they throw up in terms of sort of ethics and communication and limits of what we can and can't do, and the impacts on me. So it's really a sort of exploration of ICU and that borderline, between life and death, really, and what it all means. That's the idea. And I've just handing in the first draft today. So.
Oh, first draft today. Well, congratulations on that. But you mentioned at the end of life support, you mention that we don't have enough ICU beds compared to everybody else in the world, or all the other. Tell us a touch about that. We've got a couple of minutes.
Yeah, no, I mean, historically, we've been very low on ICU beds. I mean, compared particularly with Germany, the USA, we've sort of got half the number of beds they do. Now that's improved with COVID, which is a huge plus and a very positive legacy. And I think it's become much more clear what we do in ICU. But one of the things I really look into in the book is what should we use ICU for? Traditionally it was really for people who, the young motorbike accident or the young 30-year-old with COVID, but actually should it just be for those people who have got years of very good life ahead, or should we use it more flexibly for people with, chronic health problems? And there's endless questions like that, which is what I'm trying to go into. I have to quickly ask, is that Alistair Hignell, the journalist?
Yes.
Oh, so he taught me history at school.
He taught you history at school, and
did.
he's on next week on the Purpose, Passion and Grit. I'll let him know.
Yeah.
Brilliant. He's a great inspiration because he's MS, and he.
Yes.
Yeah, we will pass that on.
I'll pass him on my best. Yeah, please.
Definitely do that. Justine says, beautifully clear, transparent answers. Many thank you.
Thank you.
Steph,
Thank you very much.
Steph says very inspiring, and we have, goodness, we have a couple of messages. Fascinating interview, from you. And Jean Joyce says very inspiring and interesting. My daughter's had an exhausting couple of years working through the impact of COVID for her patients. So I presume a fellow NHS worker there. One new message before I have to say goodbye. Brilliant, Maria Collins. You have saved many lives. So whatever depression grabs you at 4 in the morning, you have saved many lives, Jim. That's it. Dr. Jim Down. Come back and talk to us, please, when your next book comes out. And thank you for sharing.
I'd love to. It's been a great pleasure. Thanks so much. Thank you.
Thank you all for listening. Alistair Hignall, buy and read Life Support. We've got it up there. There it is for the next thing, because it cuts through all the fog, as I've said. Alistair Hignall, who is your tutor, taught you.
Yeah, at school.
And Mary Peters, thank you all for being here. Stay safe, stay active, stay involved. And thank you, Jim, so much for your time. Now you better get back to work and start.
Thank you, yeah.
Good. Bye, everybody.
Bye-bye.
Bye.